Hello, I'm Ineba working at Korean University Korea Hospital. This is GBC's 10 Precision. Today's topic is palm nose technique of liquid biopsy and its clinical applications. So advances in cancer therapy have dramatically contributed to the decline in breast cancer deaths over decades. But even with these advances, drug resistance remains a serious clinical challenges. So how exactly do cancer cells evade the drugs? And what is the next strategy to prevent or overcome the drug resistance to improve the clinical outcome in breast cancer patients? And what roles the new technology like liquid biopsies can play? Maybe many Korean scientists and physicians have those questions in their mind in every day. So please enjoy today's episode with Dr. Sarah Chandrapari. Dr. Chandrapari is a laboratory head at the Human Oncology and Pathogenesis Program at the Memorial Sloan Kettering Cancer Center. Hello, Dr. Chandrapari. Thank you for joining me.
Thank you for having me. It's great to be here.
I appreciate your time. Please introduce yourself to GBC's TV audience first.
Yeah, my name is Sarat Chandralapati, and I'm a medical oncologist focused in breast cancer, and I am a lab director for a lab that really focuses on understanding mechanisms of drug resistance in breast cancer and developing new therapies for breast cancer.
Yeah, let's move on to your research. Recently, I saw your paper which showed the mechanism of resistance to PIK3CA inhibitor or CDK4/6 inhibitor with the endocrine therapy. Can you briefly explain the novel mechanism that you found out and its clinical implication?
Yeah, so for CDK4/6 inhibitors, what we found are there are two major classes of mutations that cause resistance. One causes CDK4/6 to still be on and active despite the drug. That would include high levels of CDK6 and several other things like that cause high levels of CDK6, like FAT1 loss was another one we found. And we have others that we're currently about to submit it for publication. The second class would be those that bypass the 4/6 kinases. So RB loss would be the classical example of that. The implications are that these two would have very different strategies for how you would target them. Something that bypassed CDK4/6, you would really need to think about targeting in a fundamentally different way than something that reactivated 4/6. One can imagine a different 4/6 inhibitor or inhibiting 4/6 together with something else upstream, PI3K, whatever. Whereas with RB loss, you really wouldn't go after that sort of mitogen activated signaling pathway. So that's for CDK4/6 inhibitors and their resistance. And of course, we're working on new inhibitors as well as strategies for the RB negative types of cancers. For PI3 kinase inhibitors, we found, again, those are given in combination with anti-estrogens. They're not given alone. That's because those pathways, PI3 kinase and estrogen signaling, cooperate. And so inhibiting just one or the other is likely insufficient. What we found is that you could develop resistance either to the PI3 kinase or the estrogen arm of things. You could either develop PTEN loss for the PI3 kinase inhibitor part, or ESR1 mutations in the case of where we're giving an aromatase inhibitor. And so I think that's going to hold up for combinations with fulvestrant and so forth, that either arm can be potentially a way that the cancer evolves. The implications are, first, I think that we need evidence from SOLAR-1 and other trials to validate this in a bigger study than our smaller phase 2 study. But that if you do have PTEN loss, probably this isn't the combination to use. That we do need to optimize both the PI3 kinase arm of things as well as the anti-estrogen arm of things. So I think that's where the research field needs to go. I mean, there isn't anything currently to say this patient should or shouldn't get this, other than if they're a PI3 kinase mutant and ER positive, this is an effective regimen. But we're hoping that we can refine that a little more, because we all have the clinical experience of some patients doing very well and some patients having much broader benefit.
Yeah, so maybe early detection is very important to determine the treatment that is next to overcome the drug resistance. So let's move on to the next topic, liquid biopsy. So many researchers in cancer field have demonstrated or argued the usefulness of liquid biopsy in cancer care. So for you, what is the liquid biopsy and its target, the target range, and the method of detections?
Yeah, okay. So I think liquid biopsy is a very broad term to encompass technologies to take products of cancer, shed products of cancer, and detect them from a vial of blood. Those can be shed DNA, those can be exosomes, those can be actual tumor cells. Any of those are potential liquid biopsies. And they are, of course, surrogates for the rest of the cancer in their mutation profile, in their abundance, and in their amount, and in their potential response to the therapy we're giving. In all ways, they may represent a surrogate for, obviously, the cancer that we want to know about, which is the actual tumors. And so currently there are new modalities for more sensitively detecting those different shed products and for characterizing them, right? So it's more than just to say we have evidence of cancer at a certain amount, but perhaps we can say, what is the type? So what are the mutations? And finally, we can use these in time, right? We can look at how these things change with time, with therapy. And that added information, the added dimension of information, can greatly increase the power and the utility of these methods. So a little difficult to say what is the exact limit of detection. It depends on, the extent of disease. So that leads to a certain amount of tumor cell or a certain amount of DNA in the blood, not just the technology that's evaluating it. So one panel of looking at mutations, DNA might be able to detect 0.1%. A more personalized modern assay maybe can detect 100 times better than that. But there isn't much DNA there, then either one's not going to find it. So it depends a lot on factors such as the amount of the DNA, the number of mutations, the type of analysis being done. But I would say that newer technologies have emerged that allow us to be more sensitive, but also to learn something about the thing that we are detecting. That is, very practically speaking, I just told you about, PI3 kinase and PTEN and ESR1. Well, we can not just tell you there's cancer and there's less cancer, there's more, but we can tell you, oh, there's a new PTEN mutation. Oh, there's a new ESR1 mutation. And so that granular information may give you insight into how to treat, not just the need to change treatment.
Yeah, we can trace the evolution of cancer cells using serial liquid biopsy. And so many clinicians or researchers are very interested in the cell-free tumor DNA. Yeah. So, but in fact, in the case of breast cancer, treatment decisions are made based on the expression level of ER, PR, and HER2. So it's unlike with lung cancer or melanoma, in which the specific genetic mutation is very, very important. So actually in Korea, breast cancer clinician do not use the DNA sequencing heavily in daily practice. So in that situation, what is your opinion on clinical utility of liquid biopsy, especially self-tumor DNA in breast cancer field?
Yeah. No, I mean, you hit the nail on the head, and I don't think it's substantially different here in the United States. We use these assays because they're useful. Where are they useful? Well, they're not useful in guiding hormone therapy or CDK4 inhibitor therapy or chemotherapy at present, because you can just give those therapies. Where they are useful is in, for instance, a PI3 kinase inhibitor, which is only approved for PI3 kinase mutant cancer. Increasingly, however, I think that these data are going to inform our decision making, because we are going to get more and more information about which cancers respond to which therapies. We're not going to probably have as many one-size-fits-all therapies. We are entering the era in which we are identifying, I think, many more specialized therapies, if you will. So we're not there yet, but I think that the value is coming.
Do you have any experience or opinion on the usefulness of self-tumor DNA in early detection after a surgery or very early breast cancer, or any early signal of tumor progression to resistance to current treatment?
So great question. I mean, one of the really amazing possibilities here is that we could have an assay to tell us about who to give adjuvant type of therapies to, right? The premise of adjuvant therapy is there is minimal residual disease, but we don't know if there is. We're just guessing. If we had actual evidence for it, then we could both give therapy to those who need it and follow it, and we could spare those who don't need it. So the promise there is quite great. All of us enter into discussions with our patients about giving them adjuvant therapies without any idea if they need it at all. Or with just a risk assessment based, I should say, not any idea, but limited. We don't know for sure. And so this offers the opportunity for a more granular look at whether or not there is residual disease. So we're doing this in the research setting. We are looking at our patients post-surgery, post-adjuvant chemotherapy. Is there evidence for cancer in very, very sensitive circulating tumor DNA assays? We, of course, know there is prognostic information for those patients who have it. There's extremely high risk of relapse. And so we're trying to design clinical trials to test new therapies in those patients. So that's really what we hope is the ongoing, research, and we hope where we will be in a few years, that we'll be able to afford those patients at very high risk something new and curative.
Yeah, in that point, we had the SWOG S0500 trial. This trial had very interesting scheme that if the number of CTC was going up, change the treatment chemotherapy regimen, And if the number of CTC was stable or decreasing, they maintain the current treatment. So, but unfortunately, this trial failed to demonstrate the improvement of overall survival in metastatic breast cancer. So I assume that there is a big challenge that in how to treat the patient if they have the positive in CTC or cell-free tumor DNA, especially in early breast cancer or after the treatment, complete treatment. So, what do you think the main reasons for this study's failure, and what do you think is the more advanced we now have?
Yeah, it's a great question. We have always had prognostics that can tell us about cancers that do poorly or don't do poorly. What we need are predictors, right? What we need are not just evidence that cancer A is doing poorly a little early and cancer B is doing well. What we need is an alternative for cancer A. That's critical. So that's why I started at the beginning by saying we're doing more than just knowing whether there is cancer there or not. We are characterizing the cancer. So you need therapies that are going to work. That's the premise. And so it's one thing to say, well, your cancer is doing poorly, whether we wait for a scan or whether we detect that at 2 weeks. If we don't have another way of treating it that's better, then it sort of doesn't matter. But I'll give you an example. In the era of targeted therapies, we do have potential alternatives. So if a patient has a PIK3CA mutant ER positive breast cancer and goes on first-line CDK4/6 inhibitor, and their PIK3CA allele does not budge while they go on therapy, that patient potentially could be treated with a PI3 kinase inhibitor. And so that's giving you potentially a targeted approach to that cancer. Now, that's no guarantee that's going to work, but at least we have evidence for something that may work in that indication. Another example that goes back to PTEN loss. We now know that PTEN loss is a mechanism of resistance to CDK4 inhibitors. So giving a patient, identifying a patient early on who has PTEN loss causing resistance to CDK4/6 inhibitor would not only give you the insight that you don't want to continue the CDK4/6 inhibitor, but you probably don't want to put that patient on a PIK3CA inhibitor either because they have PTEN loss. So this is the kind of information that's going to help with the SWOG design to make it not just changing one chemo for another, which is maybe not a substantial difference, but rather something that is more effective. So it's ultimately tied to the therapy and the information that you have.
Do you have any plan to make the clinical trial using the ctDNA or liquid biopsy or metastatic breast cancer?
Yeah, so we have a couple that we're in the process of trying to get through, sort of get all our pieces in place. But yes, that's exactly the kind of designs that we are currently developing and putting together so that we can see if this sort of notion of early detection and intervention that's guided by the information can make. But we have to do that in a trial base. Maybe it won't make a difference. So we've got to do it through research.
I hope I can participate in your trials soon. And you already gave a talk in GBCC 2019 regarding the optimal sequence of endocrine treatment in hormone receptor positive metastatic breast cancer. Can you share your experience or your opinion in using the result of CTC or ctDNA analysis for patient who show the resistance to current endocrine therapy? Do you have any experience?
We're working on it. It's a really important question because for instance, a patient who is on an aromatase inhibitor with a CDK4/6 inhibitor who develops an ESR1 mutation on therapy, should we change that patient to fulvestrant with a CDK4/6 inhibitor, which might be more potent? It's a good question. What the problem has been, what else was there besides the ESR1 mutation? So that might not have been the only thing that happened in that patient causing resistance. So we're still trying to work some of this out. I mean, another example I would give is a small subset of ER-positive metastatic breast cancers have germline BRCA2 mutations. So would you want to learn early on about their progression so that you could switch them, for instance, to a PARP inhibitor? That's another type of example. I think that we're still trying to sort out how can we design a study, as I said, that allows us to do this in a research setting, not just in a ad hoc kind of way where we just try it. People, of course, do that, and they've tried it, and it may work, it may not work. But I think in a formal trial is where we need to go next. So
okay, interesting. Yeah, BRCA1/2 is a mutation is very resistant to endocrine therapy. So do you have any sequential plan for patients who have BRCA1/2 mutation and hormone positive metastatic breast cancer?
That's the question. It's not that all of them are resistant, but they may be some that are. And so that's really the kind of question we want to address. It's difficult, though, because then you get into these small subsets that you really need cooperative groups to really address together. Certainly no one institution is going to be able to have enough patients to be able to answer that kind of question.
Thank you. So unfortunately, the time is running out. The last question is, in the immunotherapy era, is there any evidence or your experience of using liquid biopsy as biomarker of anti-PD-1 or anti-PD-L1 immunotherapy?
Yeah, that's a good question. We don't have much evidence in breast cancer yet. There is, of course, evidence in other cancers that you can, for instance, detect high tumor mutation burden using a liquid biopsy. So high TMB tumors are actually an indication in any cancer, potentially for use of anti-PD-L1, PD-1 therapy. And so that's one way in which you can use liquid biopsy. The second is, of course, in other cancers, we know about certain mutations that predict for lack of response, mainly in lung cancer, the RTK mutation. So again, liquid biopsy can help you detect those. And then finally, there's been some studies published, again, in other cancers, lung melanoma, where this phenomenon of pseudoprogression, the cancer can really be informed by using 2 liquid biopsies. So if you see a circulating tumor fine, despite a pseudoprogression on imaging, you may have confidence to just keep going, and the radiologic response may be delayed. So I think those are just the tip of the iceberg, so to speak, of ways in which I think this will be useful. But we're so early in breast cancer that we have not used those significantly yet.
Yeah, thank you for your great talk. Today's episode will be very helpful to Korean researchers and the clinicians. So I hope that the COVID-19 pandemic will end within this year, and hope I have an opportunity to see you in person in your future. And please stay healthy and safe until we meet together.
It's a pleasure, and I too look forward to GBCC, the actual meeting, and of course meeting you in person and setting up more collaborations. So,
thank you. Have a great evening.
Okay.
Bye bye.
Bye.